Hello, it's Rob Casquejo here, and you're watching Dermcast.live. Today we have longtime friend and acne rosacea extraordinaire, Dr. Hilary Baldwin, and welcome to you again, Dr. Baldwin, to the studio.
My pleasure to be here. Thank you so much for inviting me.
Of course, I can't, as long as I've been a member of the SDPA and done my CMEs through this organization, I've seen you multiple times, and I swear that you teach me something, a handful of things every time you speak.
You're too kind.
So, we're gonna spread the knowledge here. Okay. Let's just share with our viewers some of the sort of disjointed questions around acne rosacea, and let's see what you have to share. Some old ideas, maybe some newer ideas, but let's see where this goes. All right. Okay.
Perfect.
So, I've heard you talk on the subject before of antibiotic resistance. So we know it's there, we know why it's there. So what can we do? Give us some hints of what we can do day to day in terms of our patients and sort of avoiding this phenomenon.
Well, let's start with rosacea, because that's an easier story. We believe that rosacea is a chronic inflammatory disorder with neurovascular dysregulation, having nothing to do with bacteria. Maybe we're right, maybe we're wrong, maybe there's a little bit to do with staph epidermidis, maybe there's a decrease in C. acnes in rosacea patients. But clearly it's not an infectious disorder requiring an antibiotic. And the reason why the tetracycline class of antibiotics work in rosacea is not because they're killing some mythical bug, but rather because they're extraordinarily good anti-inflammatory drugs. So the first thing that we can do in rosacea is to not use full dose antibiotics, to use sub-antimicrobial dose antibiotics, so that we're fully anti-inflammatory but not an antibiotic dose. In acne, on the other hand, there is a bacterium involved. C. acnes is clearly part of the process. So in acne, I feel a little bit differently. In acne, I would like for there to be an antibiotic dose when I'm using it for that condition, but only for a short period of time. Month, 2 months, maybe 3 months at the most. And then sometimes I do switch to sub-antimicrobial dose doxycycline. We have data that shows that it works for acne, but I don't think it works all that well right off the bat. I think it's a step back from a full dose, especially if we're also using a topical antimicrobial like benzoyl peroxide.
Right. So let me dissect that a little bit. So in acne, we understand fairly well the process of adolescent acne.
Right.
C. acne is a big part of that story, the microcomedone a big part of that story. And then we know that adult acne is a very different story,
right.
Probably a story we don't even understand as well as we do teenage acne.
Right.
So do you feel different about antimicrobial doses of antibiotic in chronic adult acne especially?
That's a great question, and one that has never been asked of me before. Applaud you on it.
Well, see,
I've
been watching you for a long time.
A lot of thought. I think you're absolutely right. And in adults, it's even more important not to be on an antibiotic. First of all, when you're 16 and in need of an antibiotic to make your acne better, that acne is probably going to be gone in 2 or 3 years. But when you're 25 with acne bad enough to warrant the use of an antibiotic, when is it going to end? Mm-hmm. 40, 50, 60, you can't be on antibiotics for all that period of time. And then, to your point, is the pathophysiology of acne the same in the adult population? It's probably much more to do with the sebaceous gland and the production of androgens by the sebaceous gland than it is the presence of C. acnes. So even more important in the adult patient to be thinking about an anti-androgen, whether it's topical or oral.
Right. So you've talked in those topics for a long time. I haven't heard you talk much, at least me personally, I know you've done it. I haven't heard you talk much about laser. So tell us about your experience with the lasers that are available specifically for acne.
Right. Well, I'm not much of a laser maven, but I was a blinded investigator in the Cutera trial for the 1726 nanometer laser. I've had nothing to do with the who makes the other one, a Cure, I think.
Yeah.
So I was tremendously impressed. Of course, I was blinded, right? So all I know is that there were patients in that study who were isotretinoin worthy and got better.
Okay.
So, I'm not sure that everyone has that kind of response, but between the data and the photographs that I saw, I was quite impressed. And it's something that, of course, can be used during pregnancy. and avoids this whole issue of antibiotic resistance that we've been talking about. So I think both of them are probably a huge benefit to our patients. Now, the one issue with them, of course, is that they take an awfully long time to work, right? In the studies, the patients were treated every month for 3 months, and then the end point was 6 months after that.
Right.
So this is not a treatment that you use for someone who comes in 2 weeks before their wedding and says,
Right.
how can you fix me?
Yeah.
So in my practice, I would see it as something that I would use in conjunction with short-term treatment. So perhaps start an oral antibiotic and topical medication and start the laser at the same time, and then be able to discontinue the antibiotic and move forward with the improvement created by the laser.
Right, and I think that thinking of the time frame you just mentioned, that 6-month endpoint additionally to, I guess if someone is really trying to avoid systemic medication, a course of isotretinoin is 20 weeks up to 24 weeks as right on label. So they're going to be waiting a little bit anyways and dealing with the therapy.
Right.
I think the biggest barrier, and I think you might agree with the laser, is the cost. I mean,
Yes.
it's not the cheapest thing in the world,
No.
so there's a bit of a barrier there.
Yeah, and I practice in the heart of Brooklyn, so most of my patients are not going to be able to afford something like that. And the other question is duration and durability of response. Frankly, if you told me that for $3,000 you could cure my acne for life, what do I mortgage? Where do I sign?
Yeah.
But if I'm going to have to do this again in 6 months, in a year, I might not feel so happy about parting with that kind of money. But they have some data that shows that in some patients the response is very durable. And if they do end up requiring treatment again, that it's not as significant a treatment as it was previously. So I look forward to more data on the durability of response.
Right, great. And you mentioned sub-antimicrobial dose doxycycline. So I remember when that medicine sort of came out in the studies that they published, and there was a suggestion, the throat swabs, and they looked at the bacterial resistance with full dose doxycycline versus the sub-antimicrobial dose. So where is the world experience at this point? Do the sub-antimicrobial doses actually help with resistance? Are they effective in avoiding the increase of resistance?
That's another great question. The study that you're referring to was a 9-month study, and clearly showed that the use of this medication for a 9-month period of time did not increase the development of resistant organisms in the mouth.
Right. It's fairly convincing, just for what it was. Yeah.
Exactly. Very convincing. That's a very good way to phrase it.
Yeah.
Very convincing for what it was. But of course, it doesn't tell us what's going on in the gut, does it? And even if you were to do, let's say, stool samples, that doesn't tell you what's happening in the colon. That tells you what's happening in the stool itself. So it's very difficult to actually tell, to determine whether or not we can say that it's clearly not an antimicrobial dose. But we don't seem to run into problems in patients treated with this medication that we see with full dose antibiotics. So I feel fairly cogent, but I feel comfortable using it in my patients and saying, look, it's certainly better than full dose antibiotics. The real question though is, okay, so supposing you can't get the sub-antimicrobial dose for whatever reason because it's too expensive, the insurance company won't cover it. What do you do then? Do you go to 50 milligrams? Because 50 is kind of close to 40, but no, 50 is an antibiotic dose. We know that. So if you're going to have to go for an antibiotic dose, are you better off with 200 milligrams a day?
Right. Just sort of knock it out of the park.
Yes.
Right. Yeah. Instead of.
I feel like 50 milligrams is tickling those bacteria.
Right. I use the terminology soft doses. You're just sort of tossing soft doses at the the microbial.
I mean, we've got no data, but that makes me very nervous.
Right.
So if I go to full dose, I'm at least at 100 milligrams a day.
Right. Yeah, it makes sense in terms of what we know about the biosphere, the normal growth rates of bacteria and so forth.
Because it's 50 milligrams in that study that we all talk about with antimicrobial dosing is very, very close to the antimicrobial threshold. So that means on a day when you take it after you had something to eat, maybe it's at the threshold, maybe it's even below it, and then the next day it's above it. So theoretically, you could be going on and off and on and off antibiotics.
There is I think that this is forgotten because the branded medicine for the sub-antimicrobial dose was so long ago, and
Yes.
the brand isn't really so available. People forget that the dose is actually very specific, right?
Yes.
It's 37.5 milligrams, and on top of that, it is actually 2 different medium of doxycycline, so there's an immediate release, and then there's a slower release that
30
comes
and
later.
10, yes.
Right. So it's not the same. You could actually
No.
take a 37.5 milligram
Right.
pill. It's still not a same delivery.
No.
And I'm sure that has a lot to do with it reaching the threshold or
Right.
not at any
Right.
given time point.
Exactly,
Right. Yeah.
exactly. And
Right.
some people say, well, cut a 50 milligram tablet in half and take 25. Who knows?
Right. Yeah. Right.
It's
so
very
still
muddy.
it's still there's still some
Yes.
some schmut around that. Then we don't some stuff that needs to be figured out. That maybe experience will hash it out one day. Okay. So we're on this subject of long-term control. We started with trying to avoid resistance. So let's say let's think positively. We get the acne patient, the adult acne patient. Now you've battled through. You got them under control. They have occasional flares. Do you have like an one-stop, like this is the medicine, topical medicine I want you to use indefinitely for your control and prevention?
Well, I have a concept, one-stop concept. My concept is definitely want a topical retinoid to prevent the development of new lesions theoretically. It stops the microcomedo from forming to begin with. Stops is probably too strong a word, but reduces its production. So theoretically can reduce the development of new lesions as well as taking care of the ones you have. And, let's face it, if we're talking about an adult woman with acne, also happens to have some anti-aging effects that
Sure.
are not exactly unwelcome. So a topical retinoid has to be there. In a patient who has maybe a little bit more severe disease, I would throw in benzoyl peroxide there as well. So we have a combination of tretinoin and benzoyl peroxide, which I think would be ideal. And then we have the new triple combination with clindamycin. And there we don't need to worry about clindamycin resistance because it's in association with benzoyl peroxide. So
Right.
Either one of those drugs would be my go-to,
Right.
or benzoyl peroxide and adapalene as well.
Right.
So any one of those I
Okay.
think would be very useful for maintenance
I
therapy.
dig it. I'm smiling because you're an old schooler. Like that's an old school answer, but I think it rings true. We know that they address some of the core problems
Yes.
of acne as we understand it.
Yes,
So,
and you could also throw in there clascoterone,
Sure.
especially for
Yeah.
your adult patient, as a standalone or with a topical retinoid.
right. Okay. So let's shift the conversation a little bit more towards rosacea for a second here. Redness. We know this is the bane of this condition.
Yes.
So what are your sort of street level suggestions for redness control, redness reduction?
By street level, you mean over the counter?
Yeah, well, I mean, it could be the stuff that you do very commonly and
Right.
that you
Okay.
just say, hey, I'm confident this will help you with redness. This is what you should do. And
Well,
so
I
it could be
think-
either, I suppose.
So the first thing we have to ask them is, do they have any particular triggers for their redness? And if they do, of course, they have to avoid those. But that's not so easy, is it? Because it can include being cold, being hot, being angry, being excited. Easier to avoid food items and beverage items, but for me that means coffee and red wine, and that ain't happening.
Right.
So
yeah, you got to live.
yeah, really. So I have my oxymetazoline on today,
Yeah.
as I always do. So for prescriptions, love oxymetazoline, love bromonidine. I think they're extremely helpful. And everybody got kind of nervous because bromonidine had that initial problem with rebounding. But hey, that was back when we were telling people to use 5 pea-size amounts on their face. If you use a little amount and you do some barrier repair first, you don't have that high level of rebounding. And both of them are awesome drugs at reducing redness. There are some over-the-counter products that you could consider. We have lycochalcone A, we have neurosensine. But frankly, those don't work nearly as well as the alpha agonists do. And, for my money, I'll grab the alpha agonist and use it on a daily basis.
So let me just rewind a little bit. Can you just expound on your hints at avoiding rebound with the alpha agonist? Because that is probably the biggest concern that people might have.
Well, parts of it you can avoid. There was a paper out that suggested that if you repair the barrier first, that part of the problem with the rebounding was that the barrier was in such disrepair. So take a couple of days to use quality moisturizers.
Implying rapid absorption.
Right, exactly.
Okay, right.
And use a small amount. And perhaps moisturize first, right?
Okay.
And then put on the small amount. Not nearly as much of a problem for oxymetazoline as it was for bromonidine, but both drugs I think you can utilize as long as you sort of prep the skin a little bit to reduce the redness. And it works so much better than the over-the-counter products. I'm not sure, I certainly don't try the over-the-counters because they don't work as well for me. And then the other thing, we don't have the data with bromonidine, but I'm sure it's the same as it is for oxymetazoline, that if you use oxymetazoline on a daily basis in their long-term study, their 52-week study, they saw that by the end of the study that 11.5% of patients didn't need it anymore. When they came in for their treatment at week 52, they were unread. So there was some kind of disease modification happening by daily application. So I used to tell my patients, put it on when you care. On a Sunday when you're staying at home and eating bonbons with your dog and watching old movies, your dog doesn't care if you're red.
Right.
Don't use it. I was completely wrong. We can, the 52-week study showed clearly that more and more and more people did better as time went on.
Yeah, I may have to change because I was in the same boat. I'm currently in the same boat. I tell them, hey, just use it when you really need it.
Yes.
So that suggests otherwise. Oh, that's interesting. Okay, let's. You mentioned the alpha agonists. We have all the antibiotics, and there's a lot of generic versions of this, right? So there's all these compounding pharmacies that may have an alpha agonist mixture. They may have generic tretinoins. What is your feeling in general with generic medications? Are we okay with these in these, especially difficult chronic conditions?
Well, in acne and rosacea in particular, I'm quite a brandaholic. I think in both conditions, these medications, well, let's take acne, for example. Trying to get used to a topical retinoid is very difficult. And the new branded products that have these incredible vehicles that make them so much better tolerated is I think, the best way to start off our acne patients. Rosacea patients have a dysfunctional barrier. They too need these products with these gorgeous vehicles in order to get them better and not cause additional irritation, which just frustrates the patient and makes them stop using their products. So I think branded products, if the patient can afford it, if you can get it for the patient on their insurance, is very important for acne and rosacea. I don't feel that way, by the way, necessarily for psoriasis, for atopic dermatitis, and for all steroid-responsive dermatoses. I'm very willing to use a generic formulation, although I still think that the quality vehicles really matter. But in acne and rosacea, I think it's critical.
Okay, great. So let's end on isotretinoin.
Oh, good.
Because it's kind of relevant to both, right? Can be relevant
Yes.
to both. So most of us, know what we use the isotretinoin for, where we're going to use it. How do you feel about multiple courses on isotretinoin? I know what the label says,
right.
Okay, but where do you fit this in terms of, let's say, multiple courses throughout a lifetime of someone who has especially recalcitrant nodular acne adults?
I don't think there is such a thing as too much, to be honest with you. I've had people in 5 courses, 6 courses. They get frustrated, but the good thing is that as time goes on, you know what to expect. I think the first time you put somebody on isotretinoin, you're a little nervous. How are they going to respond? Are they going to have side effects? The patient's nervous. The parents are definitely nervous. They're waiting for the other shoe to drop the entire time the child is on the course of medication. But once they've been on it once or twice, you know they're not going to have problems. You know what to expect. The parents are fine with it. Everybody's fine with it. So start the pill again, and they get better almost immediately. And with these the patients who need multiple courses, I frequently go on to long-term low dose and have them take 10, 20 milligrams a day, maybe 3 times a week, in an effort to keep them under control. Now, as your numbers go up higher and higher and higher, you do have to start to think about calcification of ligaments. And so I frequently will send a patient off for an x-ray. For some reason, the wrist and the ankle seem to be the best things to x-ray in that regard. So if I'm up in the thousands of milligrams per kilogram, I'll check that every now and then.
Cumulative lifetime dose.
Yeah,
right.
but I don't, I'm not worried about continuing the use.
Got it. Okay. And depression, right?
Yes.
Well, let me ask you this first. So it's your opinion that the world experience has shown that the cumulative dosing of isotretinoin doesn't increase any of the known label risks per se?
Right.
Okay. So depression,
Yes.
which is the hot button of this
Yes.
medication, right? Is this any history of depression? Is it a hard stop for you for isotretinoin?
Absolutely not.
Okay.
You know, the odd thing about depression and mental issues altogether, anxiety as well, is part and parcel of being 15 to 25 years of age. I mean, this is when all major depression starts and schizophrenia begins. So people between the ages of 15 and 25 are prime for all of these issues, and suicide is the second leading cause of death in this age group. And then acne itself is an independent risk factor for depression, especially in boys who have severe acne. So you've got 2 independent risk factors. Starting off, baseline background noise is a very high incidence of depression. There is no evidence, though, in 2 meta-analyses that adding isotretinoin to that pile of background noise makes any difference whatsoever. In fact, it looks as though using isotretinoin actually improves the rate of depression in most of our patients.
Right.
So I'm not worried at all. But I have a very high index of suspicion because my patient might very well have depressive symptoms having nothing to do with isotretinoin, and that's still my job to pick it up.
Gotcha. Okay. So the backdrop depression, any history of depression, that's different than diagnosed, confirmed clinical depression, mood disorder. So patients that have that, and maybe let's say they're even being treated, managed on medication, is that a hard stop for isotretinoin?
Nope.
Okay.
It's even better because the patient's plugged into the system. The patient has a therapist, the patient's parents know what it's like, the patient knows what it feels like.
So you have some help. You got,
Yeah. And everybody is so plugged into the system and really is watching this kid. I feel more comfortable with somebody who's plugged in than I do with somebody who's not.
Okay, excellent. So one last question about isotretinoin. Post-isotretinoin therapy, where are we with surgical procedures? The guidelines, I know what the guidelines say. Where are we? What has your experience taught you?
Well, there was a large consensus paper that was written by numerous people who are laser people and chemical peel people and surgical procedure people, and they got together and discussed what data there was that suggested that you not touch the skin basically for 6 months after or during isotretinoin treatment. And they concluded that with the exception of ablative lasers, that you needn't worry. So for most of certainly the light chemical peels, if you're going for a heavy chemical peel, that's a different story. You don't need to worry.
Okay.
So
the more aggressive peels, ablative lasers,
Right.
you're sticking with the guidelines.
Yes.
Right.
Yeah.
Okay.
But other than that, there doesn't seem to be any reason why you can't go full speed ahead on the other procedures.
Okay, I dig it because that's the way we've been
Yes.
practicing in our practice. It's always nice to get some validation from the head honchos.
Well, it's not from me; it's from the
Yeah.
consensus papers.
Okay.
So
Well, I'll still give you the
okay,
credit.
at least I read the paper.
Right. So, well, awesome. So let me ask you a quick question here. So let's get into the mind of Hilary Baldwin here a little bit. That's not dermatology. So you're in the Bronx, Yankees or Mets?
Oh God, Yankees.
Okay, all right. Just checking. I made it to Old Yankee Stadium before they
Did
tore
you?
it down. It was the last of the great parks, the old parks that I
Yes.
had been into, and I'm so glad I got it in the year before they tore it
Yeah.
down.
Yeah,
So.
no, go Yankees, full
Awesome.
speed ahead.
Okay, all right. I'm just checking on you. My friends back in the Bronx, they might, have something to say to you. But all right, you're faithful.
Absolutely.
I dig it. All right. Well, thank you so much as always.
My pleasure.
Your knowledge, your experience is so valuable to us as professionals, and your support of us has been undaunted through the years, and we appreciate it very much. It's always great to have you.
My pleasure.
Yeah, come by again.
Okay.
Yeah. all
Anytime.
right. As long as I ask, you're going to keep coming, right?
Yes,
Okay.
absolutely.
I dig it. All right. You're watching Dermcast Live. It's Rob Casquejo.